whether it's breastfeeding, whether it's formula feeding, there's always someone observing that first feeding for assessment of making sure that there is no problems with that GI tract. So what do you do if there's a problem? Well, it needs to be corrected. It needs to be corrected. So whether it's EA or whether it's TEF, that child needs to be NPO. And they usually put a nasogastric tube in for decompression purposes. Do you know what I mean by that?
Yeah.
Okay, so it's hooked up to suction. It's actually draining anything that might be there because you normally will accumulate fluids like saliva, right, into your mouth, and then you're going to swallow. That's going to go there too. So you want to make sure that there's nothing that's going to put more pressure on that pouch or drain into, especially drain into the lungs. Those that have TEF are start on antibiotics. Makes sense, right? Because you want to make sure that nothing was aspirated and you can prevent pneumonia. So broad spectrum antibiotics.
The MG tube is just going to the bottom of the pouch, right?
Correct.
There's no way to get to the stomach yet.
That's right. So the whole purpose, like I said, is for decompression. Air. Because you know, a lot of air. When an infant cries, they swallow a lot of air. That's going to hurt. Do you know what I'm saying? It's going to fill up. It's going to hurt. You know, they're going to, even just saliva, you know, things like that. When they suck, they naturally have a sucking, you know, ability that will, you know, sometimes, and even giving a pacifier is not necessarily a bad thing, but again, they have to have some decompression of that area because it's going to create saliva.
And this is something that you would see on sonogram if they had oatmeal. So most of the time, you know this is coming.
Correct. But there are times, you know, where again, prenatal care is poor. And what would make somebody have poor prenatal care, Melissa?
The things that predispose the kid to getting this.
That's absolutely right.
They're doing things during pregnancy that are causing the malformations.
That's right. Do you understand what we're saying here? So somebody who's abusing drugs, somebody who's drinking alcohol excessively, is not going to maybe seek out the good prenatal care they should and follow up like they should because there's other things going on. And then they're at risk of having these issues, and then they're also at risk of it not getting diagnosed, along with cardiac defects, renal defects. So this brings me to my next point. When do we correct this? How do we correct this, and when do we do this? This is not a quick fix, unfortunately, because it's the GI tract. And again, when we go back to our priority, okay, kind of like what you were saying, we were talking about before, Deanne, when we look at priority, GI is not up there with cardiac. It's not up there with some respiratory. So if I have an infant who's born preterm, because maybe the mother was on something, or because whatever reason, if they have so many congenital defects, because those also predispose infants to preterm labor. All these things we're talking about predispose them to preterm labor. So now we have underdeveloped lungs on top of all of this. Can we bring them in for surgery? So now what do? We can't feed them. We can put in what? Yeah, a G-tube. So these are the infants who might get a G-tube, still get fed, ideally breast milk, you know, if we can, because it's the best thing. It helps build up some more immunity too, helps their GI tract function better, but we cannot feed them orally. So they get a nasogastric tube for decompression, they get a G-tube for feedings, until we can safely bring them to surgery. Now they might go right away for surgery if there's nothing else going on. But if they have a major cardiac defect like a tetralogy of Fallot, which we talked about last week, or even a respiratory problem like that they cannot breathe on their own, they're not going to be candidates to go to surgery right away. Does that make sense? So some people say, well, why don't they just do surgery right away? Well, those are the reasons why. But if they are okay and stable, they will send them sooner rather than later, obviously.
If they're not breathing on their own and they're already on the vent, will they do surgery? Because they're already on the vent?
They're going to stay long on that.
Well, go ahead, got
They're
it.
going to stay long on the ventilator. I mean, more than like 6 feet probably. So.
The goal is to always wean them off the ventilator. So you want to give their lungs the best chance. So what they're really focused on with that is they're going to try to give them enzymes. They're going to try to give them steroids. They're going to try to mature their lungs. Because the last thing they want is to make them more compromised by cutting into their GI tract, which is dirty. You know, I mean, there's already, you know, there's going to be flora in there too. That's going to be, you know, E. coli and things. So the last thing we want to do is expose them to be more compromised after a surgery, which will, for a small infant, put them more at risk. So I see what you're saying, like they're already intubated, just bring them in, you know. But for the GI tract purposes, we have a way that we can safely feed them until their respiratory status is stable. Surgeons always pause when bringing a patient on a ventilator into surgery. It's very hard to get somebody off of the ventilator sometimes, and also they're trying to mature those lungs. They're trying to not compromise them more. You know what I'm saying? Like make them more immunocompromised even. So sometimes a GI tube is a nice alternative until they can stabilize and have them breathing on their own. And again, their prognosis is really related to the second thing that's right there, well, both of those, but really it's so big that what are the other issues for them? If all they have are TEF or EA, they're very treatable. You know, they give them antibiotics, especially because the nurses there, the healthcare providers, they're watching that first feeding, and they're going to catch on to it real quickly, and they're going to treat it. But the key is, you know, what else is going on with this infant? Because if they have all these other congenital defects, it's not that easy to just treat this. Do you know what I'm saying? So that's where it becomes more complicated. So what are we going to do? They have to be MPO. They get IV therapy for fluids and electrolytes. We want them semi-upright all the time. You know, we always say supine, supine. Obviously, these infants are going to be semi-upright. Why? That's right. That's right. It's for aspiration purposes. Low, intermittent, or continuous suction with the NG tube. We talked about why, right? Broad spectrum antibiotics. Thermoregulation of the child. Why am I worried about their thermoregulation here? Very good, Denise. What happens when you have a newborn? I know you learned about newborns, right, in OB. What happens when you have a newborn who is cold? Yeah, they're using up, their energy demands increase. We don't want this infant to be stressed in any way. And comfort measures to decrease air swallowing. And if surgery is delayed long enough, obviously you're going to need the G tube. Really more than a few months. Provide non-nutritional sucking and parental education. Okay, so let's talk for a minute about colic. What is colic? Anybody ever come across a colicky infant? Okay, so tell me for a minute, Sylvania, what was your experience with a colicky infant?
My name is, she would be crying every day after eat something, and then her mother would try to make coffee, would be crying the whole time. There's nothing that could help besides warm compared to something that could fall asleep.
What did your niece look like in terms of health status? Was she thin? Was she malnourished looking?
No, I cannot.
That's right.
It was not normal, just like the fact that he ate it.
She couldn't comfort. Everybody hear what she was saying? So anybody who's seen like a colicky infant come across this will always say they're not thin, they're not malnourished, they're not losing weight. Okay, because many times the distress happens usually very much at the same time every day. So usually in the evening hours or later in the afternoon. And it usually occurs after feeding. And they manifest many things that demonstrate they would be having some kind of physical discomfort that occurs as a result of their this colic, or you know. So what you basically see is legs up, all those kind of like flack things we talk about. You know, you see the legs up, you see grimacing of the face, crying. They pass flatus. You're going to say something, Talib?
Yeah, I always thought colic was immature cardiac sphincter that caused burning after feeding.
There's a lot of things that could cause colic. But many times it often goes undiagnosed, that one thing. One of the things that could cause colic is a lactose intolerance that was undiagnosed. Okay? So sometimes that's the reason for it, because that will create more gas, create more gastric discomfort and pain, and that could lead to this. It could be improper bottles, and they have more air swallowing, which will also cause more gastric distension and more pain. Sometimes it's the type of formula, okay? Sometimes it has to do with, you're right, Talib, maybe they do have a little bit more gastric reflux than normal, immature. So the point, it could be a majority of things, but many times what they do is they rule out all the physical, and then they're stuck with the same symptoms still. So then what do they do? Well, there was this great research that was performed a couple of years ago in which they took about 500 infants and they tracked how they did, that came in with colic, and they followed pediatric nurse practitioners and they followed pediatricians in their treatment. And the pediatricians gave them Milocon, they gave them different kinds of anti-flatulence, they had them taking different kinds of formulas that had everything taken out of the formula, there's Nutramigen and these different very expensive formulas that kind of pull everything out of it. And then they had nurse practitioners who had other kinds of techniques they were doing first, like they would have the mothers do like the airplane hold or that football hold that you guys talk about, where they actually are kind of like on their stomach. I'm talking about while they're awake, kind of putting them prone and rubbing their stomach, putting them in a quiet environment, putting them into a car, changing the environment, putting them into a car and taking them for a ride. right? All these kind of things. And guess which infants did better?
The one that they used to stroll around.
The ones that they did all these non-pharmacological things with. Overall, when they looked at big categories of infants, the non-pharmacological did better. So people were saying, well, what is it then? Is it a physiologic thing? Or is it a psychologic thing? Or is it something that's doing with the... And they don't really know. What they do know is that certain infants do get this way, but that they usually grow out of it by 3, definitely by 6 months of age. So it's something that does not go through very long. But what are these infants at a higher risk of?
Shaking baby.
That's absolutely right, Stephanie. They actually have a higher risk for abuse because you have people who are stressed. And they say sometimes it's a cycle because the infant is feeling that stress. So they're responding to it, okay? So now they're crying, they're getting upset, the family's upset, okay? What is a family unit? So if you have somebody by themselves dealing with an infant who's crying every night, into the night, they're not sleeping. Maybe they work too, they have to sleep, you know what I'm saying? So it's this cycle. And the more upset and agitated they're getting, the more upset and agitated that infant is getting. Even young infants, their response is going to be feeding off of the response of the parent. So yes, abuse is very high for these infants with colic too. So again, despite the obvious behavioral indications, they tolerate formula well, they gain weight, and they thrive. So what do we do for them? Well, you want to do all the physiologic. You still should really rule out the food allergies. So again, you want to watch if you think it's a lactose intolerance. You want to give them a lactose-free formula. If they're breastfeeding, usually they tell the mother to cut down on milk in her diet. A lot of times they still say the antispasmodics, the antiflatulence do help. Massaging the abdomen, changing position, using bottles, changing bottles, and using ones that might decrease air swallowing. Swaddling the infant, car rides, changing the environment. So again, you want to try all of these. But usually they do decrease. Usually, it will decrease and end somewhere between the 3 to 6 month period, which is a very long time when you tell that to a parent who has an infant who has these symptoms. Think about every night for hours the infant will cry. They say try to change care providers. Try to change it up. Even if the parent is a single parent by themselves, it's good to have help and resources. Everybody needs a break, and sometimes they feel bad about that because it's their child. But you know what? It's better than the alternative, which is getting so frustrated that you only get each other frustrated more. So sometimes it's good to have like a night off or a break or just some hours away even. Lactose intolerance. This means that there's actually a decrease in lactase, which is an enzyme that breaks down lactose, which is a complex sugar in a lot of what we eat actually, milk products especially. So what do we do? Well, there is a higher incidence in certain nationalities and certain ethnicities. There's a higher incidence. Principal manifestations. Well, think about dumping syndrome. You learned about that last semester in 132, I want to say. Okay, so very similar here. You have a high sugar content now because that sugar is not broken down. So when you have a high concentration of sugar in the intestines, what does that do? That's right, Nadej. It's drawing fluid.